Let's talk about pneumococcal infection and the responsible pathogen, Streptococcus pneumoniae. The objectives for this lecture are: analyze factors that put the client at risk for pneumococcal infection, assess clinical manifestations and identify the complications of pneumococcal infection, formulate an individualized nursing care plan according to the client's needs, prioritize nursing interventions, analyze clients' needs, and provide appropriate patient education. Streptococcus pneumoniae is a very common bacterium. It can be found in many healthy nasopharynxes. As mentioned in earlier lecture, Streptococcus pneumoniae accounts for one of the most common causes for bacterial meningitis. It is also the most common pathogen responsible for community-acquired pneumonia. Streptococcus pneumoniae is a gram-positive diplococcus. It is non-motile and encapsulated. Streptococcus pneumoniae mainly stays and causes infection of the upper respiratory tract. Pneumococcal infection is more prevalent during winter and spring seasons. Risk factors for pneumococcal infection include the following: insufficient immunity, such as lack of or inappropriate vaccination or compromised immunity due to sickle cell anemia and asplenia. Young children and older adults are at high risk for pneumococcal infection comparing to other people. Lifestyle and chronic diseases may contribute to infection by weakening the host's immune system. For example, smoking, heavy alcohol consumption, and malnutrition. Preceding respiratory viral infection compromises respiratory system, increasing host's susceptibility to pneumococcal infection. Streptococcus pneumoniae is transmitted via droplet. Therefore, cramping living space increases opportunity to pneumococcal infection. While the pathogen is introduced to upper respiratory tract by direct contact of the contaminated respiratory droplet, pneumococcal infection can be endogenous or exogenous. The former takes place when a healthy individual with previously established Streptococcus pneumoniae colony develops infection as the bacteria spread from the primary site of nasopharynx to remote sites and cause meningitis, pneumonia, otitis media, and sepsis. Endogenous infection is triggered when the healthy carrier's immunity is compromised. The exogenous infection occurs when the susceptible individual contacts or inhales the contaminated respiratory droplet. First, the pathogen enters the victim's physical barrier. The capsule increases its virulence, and the pili helps the pathogen clinging onto mucosal layer of the respiratory tract. The incubation period is about 1 to 3 days. Then a group of focal signs and symptoms pertaining to the specific infection manifest. For example, nasal inflammation, thick and discolored nasal discharge, nasal obstruction and congestion, inability to smell, and headache manifest if the patient has sinusitis. Sore throat, difficulty swallowing, and hoarsened voice manifest if Streptococcus pneumoniae causes pharyngitis. Fever, earache with or without discharge, and upper respiratory infection manifest for those who have otitis media. As upper respiratory infection has focal symptoms, bacteremia or sepsis caused by Streptococcus pneumoniae do not manifest with focal symptoms. Instead, the patient may manifest with unexplained fever and decreased responsiveness. Communicability period is not well understood, but thought to last until 24 hours after the effective antibiotic is initiated. Pneumococcal infection can lead to serious complications. Streptococcus pneumoniae usually stays at upper respiratory tract. When it disseminates to remote sites, more serious infection such as pneumonia, meningitis, bacteremia, septic arthritis, osteomyelitis, endocarditis, and brain abscess can occur. Once the patient recovered from these serious infections, sequelae can be possible. Neurological sequelae such as hearing loss and motor deficits are associated with otitis media and meningitis. Furthermore, pneumonia can lead to empyema, pericarditis, or death. Medical diagnosis is made through culture from specimens collected from sputum, CSF, or blood. Drug sensitivity is a must. Many strains of Streptococcus pneumoniae have already developed resistance to penicillin. Medical treatment includes the following: supportive measures for focal manifestations, vancomycin or rifampin IV for those whose testing of drug sensitivity shows resistance to penicillin. If drug sensitivity testing does not show resistance to penicillin, amoxicillin or azithromycin can be prescribed. Dexamethasone is given to soothe inflammation for meningitis. Prevention is always the best treatment for infectious and communicable diseases. Vaccination enhances the individual and community immunity against pneumococcal infection. Pneumococcal infection is a reportable infection. Notify public health officials. Standard precaution is reinforced when caring for the patient who has pneumococcal infection. Note that the communicability period lasts until 24 hours after initiating effective antibiotics. Antibiotics should be given at a consistent interval, and the full course should be completed to avoid bacteria growing resistance to antibiotics. Vancomycin may be prescribed if testing results shows that the strain is resistant to penicillin. Vancomycin has increasing clinical significance as the rise of drug-resistant bacteria. It is commonly reserved to treat life-threatening infection, in which many other antibiotics are not effective. The common adverse effects of vancomycin include ototoxicity, tinnitus, nausea, vomiting, abdominal pain, and diarrhea. Vancomycin has nephrotoxicity. Therefore, monitor kidney function by checking serum creatinine and BUN. The other severe adverse effects include pseudomembranous colitis and neutropenia. Vancomycin can be given through IV or PO. When administered vancomycin via IV route, dilute every 250 mg vancomycin in 50 ml normal saline or dextrose 5% water and infuse it as soon as possible after reconstitution. The IV should be given slowly at a rate over 60 minutes or slower than 10 mg per minute. Rapid infusion can lead to hypotension, shock, or rarely cardiac arrest. If the solution after constitution is not used soon, keep it in the refrigerator and use it within 4 days. Assess IV site every shift, as extravasation can cause irritation or necrosis. Again, if the pneumococcal strain does not resist penicillin, amoxicillin or azithromycin is used. Non-aspirin antipyretic is administered for comfort and controlling fever. Dexamethasone is a corticosteroid. It is used to decrease cerebral edema, encourage fluid intake, monitor intake and output, vital signs, and level of consciousness. Changes in level of consciousness may signify development of invasive pneumococcal infection, meaning that the focal upper respiratory infection has disseminated to remote sites and causes meningitis or bacteremia. Patient education should include monitoring signs and symptoms for complications of pneumococcal infection, especially if the patient is to be treated and cared for at home. Teach the family members and client on when to seek urgent care or emergency treatment. Remind the client that the antibiotics should be taken at a consistent interval to maintain consistent serum drug level, as well as to complete the full course of antibiotics to avoid developing drug resistance. Last but not least, reinforce teaching on vaccination. There are 2 types of vaccines for pneumococcal infection, pneumococcal conjugate and pneumococcal polysaccharide. The former is the recommended routine vaccine, and the latter is the second option and can only be given to children who are at least 2 years old. Recommended routine vaccination is to administer a series of 4 doses pneumococcal conjugate at age of 2 months, 4 months, 6 months, and last dose at age between 12 and 15 months. The Advisory Committee on Immunization Practice, ACIP, updated new recommendation on pneumococcal vaccination for adults. In the update, ACIP continues to recommend pneumococcal conjugate for adults aged 19 years or older with immunocompromising condition, leakage of cerebral spinal fluid, or cochlear implants. All adults aged 65 years or older should receive 1 dose of pneumococcal polysaccharides, regardless if previously gotten one before turning age 65 years. However, the interval between doses of pneumococcal polysaccharide should be at least 5 years apart. Thank you for taking this lecture with me.